abstracts regarding acute lymphoblastic leukemia that were presented during the EBMT meeting 2022. I will focus on three issues related to allotransplants in acute lymphoblastic leukemia. The first is immunosuppression and matched unrelated donor transplants for ALL in first complete remission. Second is conditioning in the same setting. And finally, one abstract on allotransplant for relapsed, refractory, Ph-positive acute lymphoblastic leukemia. Let me give you some background regarding immunosuppression in MAT-HCT. According to current recommendations, the use of anti-thymocyte globulin, ATG, is a standard of care for patients treated with unrelated donor transplants. But particular retrospective studies focused on the population of patients with acute lymphoblastic leukemia confirmed that the use of ATG is associated with reduced risk of chronic GVHD, but at the same time, it is associated with increased risk of relapse. So in ALL, the use of ATG is associated with reduced efficacy of the transplant regimen, probably by decreasing graft versus leukemia effect. So we are looking for alternative, and in recent years, such alternative has been proposed, which is the use of post-transplant cyclophosphamide. It was originally developed for haplidentical transplants, but more and more it is also used in the matched unrelated donor setting. And therefore, the first presentation, the first paper I'd like to talk about is the one comparing post-transplant cyclophosphamide versus anti-thymocyte globulin in patients with ALL and first complete remission treated with allo-HCT from matched unrelated donor. This was a retrospective study by the Acute Leukemia Working Party of the EBMT presented during the presidential symposium. In this study, we included patients in first complete remission at the age above 18 years who were treated with their first allotransplant between January 2015 and June 2020. We included only patients who were fully 10 out of 10 HLA matched unrelated donors. Immunosuppressive protocol including either ATG or PTCy, but not both. And finally, we accepted both peripheral blood or bone marrow as a source of stem cells, while cord blood was excluded. There were no differences between post-transplant cyclophosphamide and ATG with regard to acute GVHD, either grade 2 to 4 or grade 3 to 4. As expected, there were some differences, although in a univariate analysis they didn't reach statistical significance regarding chronic graft versus host disease. There was less chronic graft versus host disease with the use of ATG. But we confirmed that the use of ATG was associated with increased risk of relapse, while no effect on non-relapse mortality. Altogether, the use of ATG was associated with inferior leukemia-free survival, and there was some trend also in terms of the overall survival. So the univariate analysis suggested that PTCy may be a better option than ATG because of reduced risk of relapse and improved leukemia-free survival. In a multivariate model, we confirmed effect of the use of ATG on chronic graft versus host disease, in particular extensive chronic GVHD, which was less frequent among patients treated with ATG compared to PTCy. But on the other hand, we confirmed that the use of ATG was associated with increased risk of treatment failure, either relapse or non-relapse mortality. In other words, it was associated with inferior leukemia-free survival. There was no significant effect on the overall survival. So the conclusion of this study was that the use of ATG as compared to PTCy, despite reduced risk of extensive chronic GVHD, is associated with inferior LFS in adults with ALL in first complete remission undergoing allo-HCT from 10 out of 10 fully HLA matched unrelated donor. And therefore, it seems that PTCy should be considered a preferable option in this setting. The second issue I'd like to highlight is the choice of conditioning for patients with acute lymphoblastic leukemia. To give you the background, TBI at myeloablative doses, usually 12 grays, is considered a standard of care in this setting. And we have a very strong evidence coming from a pediatric trial. This was a global study for patients transplanted in CR1, 2, or 3 from met sibling or unrelated donor that compared TBI 12 grays plus etoposide with thiotepa-based conditioning, the combinations with fludarabine and either busulfan or triosulfan. This study was prematurely closed due to a big significant difference in favor of TBI-based conditioning in terms of the overall survival. Can we extrapolate these results to adults? In general, yes. There was a lot of retrospective studies showing advantage of TBI-based compared to chemotherapy-based conditioning, but it is questioned whether this applies to all age populations, and some investigators postulate that maybe elder adults are not necessarily good candidates for TBI because of excessive toxicity. Therefore, there were 3 studies presented during the EBMT 2022 meeting focused on the issue of conditioning. The first one by Klaus Hirschbier and colleagues was presented as oral presentation. In this study, focused on patients above the age of 45 years, TBI in combination with fludarabine was compared with Bu-Flu. So this was a retrospective registry-based study. The TBI regimen that was chosen for this comparison was TBI 8 grays in combination with fludarabine, and it was compared with Flu-Bu, either Flu-Bu 2 or Flu-Bu 3. Patients were adults with acute lymphoblastic leukemia, 45 years old or elder, given their first allotransplant and the first complete remission between years 2005 and 2020. Only transplants from matched sibling donors or matched unrelated donors, 10 out of 10 or 9 out of 10, were considered, while haplo and cord blood transplants were excluded from the analysis. And these are the most important findings. The authors found advantage in terms of the overall survival and leukemia-free survival. For difference in leukemia-free survival was mainly due to differences in relapse incidence. The risk of relapse was the lowest for TBI 8 grays flu compared to Flu-Bu, while there were no differences with regard to non-relapse mortality. In a multivariate analysis, the effect on relapse and the effect on leukemia-free survival was confirmed. So once again, the risk of treatment failure was higher for Flu-Bu 2 and Flu-Bu 3 compared to Flu-TBI 8 grays. And the authors concluded that for patients with acute lymphoblastic leukemia at the age of 40 years or elder, treated with allo-HCT from either met sibling or unrelated donor in first complete remission, the regimen based on TBI 8 grays in combination with fludarabine is associated with better LFS compared to Bu-Flu, and therefore it may be considered preferable conditioning regimen. The issue of conditioning was also a subject of 2 interesting posters I'd like to mention. This was another study from EBMT Acute Leukemia Working Party, a retrospective one, that was focused on 2 reduced toxicity regimens in which TBI was combined with fludarabine while not with cyclophosphamide or etoposide, which is considered a standard of care for younger adults. The question was whether we need 12 gray TBI, or maybe the dose may be reduced to 8 grays. And this was the subject of this comparison. The study regarded patients with acute lymphoblastic leukemia and first complete remission given transplants from a sibling or unrelated donors. The median age was significantly different for the 2 study groups. It was 40 years for Flu-TBI 12 grays and 56 years for Flu-TBI 8 grays. As you can see, Despite that, there was no difference in terms of leukemia-free survival and overall survival, and the authors concluded that 8 grays may be sufficient dose of TBI for ALL in first complete remission, and there is no need for 12 grays. Of course, this is very provocative, and once again, it could depend on particular age populations, age groups, and I would still support the use of 12 grays for the youngest adults, where maybe in older patients, 8 grays is the optimal dose, and flu the optimal counterpart to TBI in the conditioning regimen. And finally, there was also a study focused on reduced intensity conditioning regimens for patients with ALL in first complete remission. In this case, TBI was included at the dose of 4 to 6 grays, and such regimens were compared to thiotepa-based reduced intensity conditioning regimens. Once again, patients with ALL in first complete remission were included, the age above 40 years. All matched sibling, mismatch-related, and unrelated donors were considered for this analysis. And the results, the major results, are listed in the table. As you can see, the outcomes were better for TBI-based compared to thiotepa-based RIC regimens, numerically for overall survival and leukemia-free survival. There were less relapses, less non-relapse mortality, but all these differences were not statistically significant. While, on the other hand, there was significantly increased risk of chronic GVHD for TBI-based compared to thiotepa-based RIC regimens. So the conclusions were that for ALL patients in CR1 who must be given RIC, thiotepa-based regimens are a reasonable alternative to TBI regimens. And the last paper I'd like to cite is a very optimistic one coming from our colleagues from China. This was a single-center retrospective study focused on patients with relapsed refractory Ph-positive acute lymphoblastic leukemia. I think several years ago, we would say that relapsed refractory ALL is a disaster and very few patients may be salvaged. In this study, only patients who received a salvage regimen and achieved finally complete remission, subsequent complete remissions were included. The bridging therapy or salvage therapy was most frequently CAR T cells. 21 out of 29 patients in these populations were treated with CAR T cells, while 8 remaining patients were treated with other salvage regimens. So altogether, 29 patients who achieved subsequent complete remission and were given allotransplant as consolidation were included in this analysis. The median age was 21. There were some pediatric patients, age range 5 to 59. Most patients were given a transplant from haploidentical donor, 19, then unrelated donor, 8, and only 2 from matched sibling donor. All patients were treated with TBI-based myeloablative conditioning. And as you can see, the results were excellent. The probability of the overall survival at 2 years and 3 years were 80%. Leukemia-free survival at 2 years, also 80%. So it seems that in the modern era, especially when we have access to CAR T cells, we are able to salvage patients with relapsed refractory Ph-positive ALL and effectively give them allotransplant with very high 2 and 3 years remission rates. In summary, with regard to immunosuppression in matched unrelated donor transplants for ALL CR1, we observe higher leukemia-free survival when using post-transplant cyclophosphamide compared to anti-Antioxide globulin, and therefore PTCy may be considered a preferable immunosuppressive approach in this setting. With regard to conditioning for ALL in first complete remission, reduced toxicity, it seems that 12 gray TBI combined with fludarabine may give similar or equivalent results to TBI 8 grays fludarabine, and therefore TBI 8 grades may be a preferable option as less toxic. On the other hand, we know that flu TBI 8 grade is better than flu BU. So, for patients who are not candidates for fully myeloablative TBI 12 grade cyclophosphamide or etoposide, we can consider flu TBI 8 grades as a good option. With regard to reduced intensity, thiotypa-based is a reasonable alternative to 4 to 6 grades TBI-based conditioning. A lot of centers have no access to TBI, and therefore such thiotypa-based regimens may be a really good option. Finally, for relapse refractory pH-positive ALL, in modern era, we can give effective salvage. It may be CAR T cells, but also other options like immunotoxins or bispecific antibodies that, followed by allo-HCT, may result in excellent survival. I thank you very much for your attention.